I'm delighted to have Lenny Lopez, Dr. Lopez, visiting us from UCSF. He's the Chief of Hospital Medicine and Associate Professor of Medicine. Has done really tremendous work in this area, and he's going to be talking to us about hospital care for Latinos in the U.S., acute myocardial infarction and inpatient mortality. Lenny, thank you for coming. We really are delighted to have you here.
Dr. Ogeen and Dr. Samet this morning in their presentations really highlight a continuum of health and the interaction of health with community and community health, preventive health, and systems. And in this case, I'm going to speak about when people get sick, they go to clinics and hospitals, and I'm going to specifically look at at hospitals. And Dr. Barrio, in her talk, talked about mortality disparities and gave us a list of the top 5, 6 things that lead to mortality disparities in Latinos. And one of the second one listed there was after cancer was cardiovascular disease and stroke, and talked about how in the ARC chart book, where they're tracking disparities over time, that these disparities haven't, the delta disparities haven't really changed that much over time. And to really follow up the very dynamic and powerful presentation by Rudy Gonzalez, he talked about our obligation to change the system. So I'm going to present some research that is part of my research portfolio. I don't only do hospital-based research, but I was very interested in this question about what happens to Latinos when they go to hospitals. Not only because I work in hospital medicine, let's say. Okay. Yeah, the keyboard is much better. Up here? Okay. So we know that hospital quality is important, and there's been a big movement over the last good 20, 25 years to measure hospital quality, and there's many metrics have been created over time. And we also know that measuring quality in both the process and the outcomes is associated with good things, and we want to keep doing that. And we also learned over the last 10, 12 years that hospital care for racial and ethnic minorities is highly concentrated in a small group of hospitals. And that's primarily based on demographics. We've been hearing about migration and immigration, but demographic and historic reasons. African Americans tend to live in certain parts of the country, and Latinos and Asians tend to live in other parts of the country. And from that research, we know that we have about 4,200 acute care hospitals that are non-federal, which means the Veterans Administration system. But we know that about 10% of 4,200 hospitals take care of the bulk of racial and ethnic minorities. And many of you in this room know that by 2001, Latinos became the largest racial and ethnic minority group in the country. Of course, that was always the case in minority majority population states, like in the Southwest. But until very recently, we had very little, almost no data on what happens to Latinos, and that's a sort of historic reason also, because the largest data set that we have to work with is Medicare data, and that data primarily was only valid in terms of race ethnicity for non-Hispanic whites and African Americans. So most of the work that I did early on in my career was focused on African American, Black, and non-Hispanic hospital-based differences in care and outcomes. And in order to sort of work this around recently, my group a few years ago at Boston University were able to get a grant from ARC to look at this question about how could we, going the wrong way, let's do it this way. How could we answer this question of what happens to Latinos when they go to the hospital and have an acute myocardial infarction, otherwise known as a heart attack? So the objectives of our study was to examine inpatient risk-adjusted mortality for heart attacks by race ethnicity, and to look at patient hospital characteristics around this particular outcome, because that is the ultimate outcome, you die. And then look at what happens if Latinos are going to a specific group of hospitals, I'm calling high-serving, Hispanic-serving hospitals, and compare them to other hospitals and see if the quality and the outcomes are different. So what we did was we used a nifty little approach. There are state inpatient discharge databases, and because of the geographic density of Latinos in the U.S., we were able to look at 15 states, one of them Colorado, that account for 85% of the U.S. Hispanic population. So we were able to come up with near national estimates for Latinos. And a series of papers we've already written in terms of the methods, we had only missing 1.3% of all discharges around. In this data set, it's very low for Latinos. And in this data set, we wound up having 513,639 heart attack discharges, of which 10.8% of those were Hispanics. So that was a very nice number of data. And we also used data from the American Hospital Association, which allowed us to figure out the hospitals and also characteristics of those hospitals. And then we used different algorithms to mine the data sets and get all of the detail that we needed in terms of the variables that we were interested in. And then we took those hospitals and then we created deciles so that, I'll show you this data in a second. Decile 1 would have the lowest percentage of Hispanics, and decile 10 would have the highest percentage of Hispanic patients with heart attacks. And the hospital characteristics we had are some of the classic ones that prior research, starting 20 years ago, showed are associated with processes of care and outcomes. So size of hospital matters. So that's usually done by number of beds. And then very important characteristics such as whether that's a safety net hospital, whether it's a teaching academic hospital, and also the finances of the hospital matter. There's a whole literature that for-profit hospitals don't necessarily deliver the best quality of care on many different disease processes. We also looked at volume of cases. So a hospital that has large volume of heart attacks get good at taking care of heart attacks, and those that don't do it very often are not as good. And also we were able to account for location both at a state level and then in county level. And then we were also interested, and we've been talking about this in different presentations today, about sort of area level characteristics associated with these hospitals, because we know hospitals are not all located evenly across a state. So we were very interested in using census data to get a sense of the socioeconomics of the areas that the patients were coming from, looking at education, unemployment rates, urban, rural, there are less hospitals in rural areas, and also the uninsurance rate in these state and county level data that we had. And we also wanted to account for the amount of physicians, the number of physicians in an area, because that matters also in terms of referral patterns and where people go to get their care. And from the American Community Survey, which was mentioned in the prior discussion, we were able to account for other characteristics we were interested in are unique to Latinos. So we were able to calculate percent foreign born by county level and state level, and also a percentage of language abilities. So we were trying to account for both hospital, patient, and area level characteristics. Now, this is a long-winded slide, but basically we used multivariable regression analysis methods to account for variables that we were not particularly interested in, but just to account for possible confounders, things in the pathway that might be explaining the association between heart attack mortality and Latino race and where you get your care if you're going to a high Hispanic serving hospital. So I just want to show you this because this is always very interesting to me that, in this sample, we had 55,473 heart attacks. And when we did deciles, it turns out that, in decile 10, which had the highest percentage of Hispanic patients, here we go. In this decile 10, it's only 186 hospitals that are taking care of 50% of all Hispanic patients with heart attacks. And that's a very important point to me out of a total number of hospitals in these 15 states of almost 1,700 hospitals, is because this is a point, we're talking about translation, this is a point of where we could actually drill down and look at what these 186 hospitals are doing and create quality interventions at these particular places because the impact would be large. And what we found, just getting to the story, just we have limited time, is that when you compare mortality for inpatient mortality, so this is while they're in the hospital, not when they've been discharged, so inside the hospital, Hispanics have about a 9% higher odds ratio of dying in the hospital if they go to a hospital with a heart attack compared to non-Hispanic whites. Blacks did not have any difference compared to whites in terms of their mortality rates for heart attacks. And then Asians actually had the same higher risk of mortality inpatient for a heart attack. And so this was an interesting finding for us. And then when we looked at how this distribution of mortality across this low and high Hispanic serving hospital, in other words, the concentration of care for Latinos, we find that in decile 10, we have a U-shaped relationship. In decile 10, here, this is the one with the highest number of Hispanics, even after you adjust for all the characteristics and all the possible confounders we had available in our data set, both patient characteristics and hospital characteristics and area level characteristics, they had higher rates of mortality. But it was interesting because they had the similar rate of mortality compared to the lowest decile. There was a similar study done back in 2005 by a famous working group led by Skinner that looked at this, comparing African Americans and whites in terms of heart attack deaths, inpatient hospital mortality, and they had a nice increase. So the hospitals that have almost no blacks, there's almost no mortality, and they have the lowest mortality, and then the hospitals that have a lot of African Americans have the highest mortality. So theirs was a nice monotonically increasing association, while ours was U-shaped. So we don't have a complete answer, but we looked at what characteristics were associated between decile 1 and decile 10. And this is just to simplify a lot of other things, but what we found is that the decile 10, which is where most Hispanics are going to get their care, it's a small number of hospitals, and most of them are big. They're large hospitals. You see there's only 17.7 of them that are less than 100 beds, and the 100-bed hospital is small. In large tertiary hospitals are 500 beds or more usually, and a large percentage of them are safety net hospitals. So that was one thing that we found that was important in terms of issues around, we're talking about parity and finances and everything else. That's a whole other discussion about how safety net hospitals are funded state by state and in this country. They're also more likely to be teaching hospitals where the Hispanics are going, probably because it's usually teaching centers are involved in areas that are highly urban, where there's a lot of race, ethnicity, diversity. And they were also more likely to be for-profit. And we've seen before in other papers that for-profit hospitals are more likely to have higher mortality rates and less good quality of care around heart attack care. But they also were more likely to have lots of cases, lots of volume of heart attacks compared to decile 1. So some complicated, contradictory kinds of characteristics, but we would need to sort of drill down in a different sort of analysis around those 186 hospitals to see what is different in terms of their processes of care. One of the things that we couldn't account for in this data set was the amount of procedure access, because if you go to a very large hospital, for example, you're more likely to have access to the procedures if you need them. So catheterization, getting a stent in one of your arteries in your heart, emergency cardiac surgery, things of that sort. So if you're not going to a major center, you might not have access to those things. We know that recent studies in California, just using the California data sets, have shown that Hispanics in California are more likely to go to hospitals that don't have the highest level of acute care in terms of procedures for heart attacks. So that could be part of what we're seeing in this data set. So I'm already giving possible explanations. Now, we're looking at inpatient mortality. So what's interesting about inpatient mortalities is that if everyone's getting the same level of care, the differences are between hospitals, not within hospitals. If everyone's getting into the hospital, they should all be doing fairly well. And one of the challenges in this field has been that a lot of the mortality happens after you leave the hospital. So that's an important issue because that is deeply within the realm of social determinants of health, access to proper cardiac rehabilitation, access to your primary care doctor, someone's got to give you medications to help you after a heart attack. All of these things are important factors that are not part of the inpatient mortality. So we're not doing 30, 60, 90-day mortality analyses. Those have been done, and we know that African Americans and Hispanics, at first 30 days, they tend to look okay. They tend to have lower rates of mortality after a heart attack. but after 30 days post-discharge, but then when you get to 60, 90, and 120 days, they have higher rates compared to non-Hispanic whites in terms of mortality after they leave the hospital. So we know after leaving the hospital, which is what a lot of people are very interested in, there's a lot of social determinants of health things going on. So part of this explanation of this inpatient mortality, higher inpatient mortality for heart attacks, probably are things that are pre-hospital, that have been cooking for a long time. And we've heard about these in the first talks we had today. So issues around access and insurance. We just had Dr. Schenker show us that a lot of people don't go to the doctor. So people say they're in great health, but that may not be the case because they haven't seen a doctor in 2 or 3 or 5, 10 years, or maybe they didn't have great access of care in their own country of origin. We just had a talk on immigration issues, so there's health literacy issues that probably are involved in this. One of the things we can't adjust for in this analysis is, let's say you have hypertension or elevated cholesterol, we don't know how well that's controlled, right? So the data sets just tell us whether it was there or not. It doesn't say whether it's perfectly controlled or not. So that's one risk, one factor that we couldn't account for properly. And another thing that we've discovered recently in several other studies, again, based on California data sets, that Latinos tend to live in environments where the hospitals that are in their neighborhood are more likely to be on diversion. So that means that the hospital's full or the emergency room is full and they send you to a different hospital that may be further away, or it turns out in larger national data sets, African Americans and Latinos are more likely to be sent to hospitals when their closest hospitals on divert, to hospitals that are less likely to have advanced cardiac care in terms of surgeries, catheterizations, etc. So just simple things that are systems, again, around where the ambulance takes you, how far you go away, and all of those things really can impact mortality. And we also know from other studies that Latinos are more likely to go to hospitals that have lower quality of care for heart attacks, congestive heart failure, pneumonia, and also not great outcomes on some surgical procedures. So there's a series of things, we're talking about systems, there's a series of things coming in when we talk about mortality disparities. In this particular case, we're using heart attacks that all are perfect storm factors to lead to these observed disparities. So in conclusion, our study has shown that Hispanic patients have a higher rate of heart attack inpatient mortality compared to non-Hispanic whites. And these findings were between hospital differences, not when you're within the hospital. And the hospitals that disproportionately serve Hispanic heart attack patients, serving lower proportions of whites and other minority patients, overall had this higher rate of mortality compared to other hospitals. And these mortality differences are greatest between hospitals and not primarily within Hispanic serving hospitals, consistent with other studies of Black serving hospitals in prior work. And really, it tells us the importance of having race ethnicity monitoring. The fact that we're only now being able to understand these disparities in 2018 because we finally have race ethnicity data in these state inpatient databases that allow us to look at these differences, and we're seeing things that are quite concerning. So that's the only way that you have to shine the light. I think someone was talking about this in terms of work and occupation. This is where this research is important. We now know that there's a small number of hospitals providing a large amount of heart attack care, and they may not be doing a great job. San Francisco. So I wanted to, I know we're doing Q&A at the end, so I just want to thank you all very much for allowing me to present some of my ongoing work. Thank you.